Okay, next up we have Grazia and Laraib, and they're going to talk about a paediatric oral health promotion program in a hospital setting.
Hi everyone, thank you for joining this session. I'm Grazia Antonacci from the Arno West London Imperial College London, and today, together with Laraib.
Hi, I'm Laraib. I'm from Chelsea and Westminster Hospital.
We are going to present a pediatric oral health promotion program delivered at Chelsea Westminster Hospital. So first, we're going to provide you with an overview of the key elements of this program. Then we will provide you with a flavor of the implementation and evaluation processes, and we'll present then some results of the first 2 years evaluation.
So tooth decay is almost entirely preventable, yet tooth extraction is the most common hospital procedure amongst 5 to 9-year-olds in England. Tooth decay is also inequitably distributed across the population, and we know that it causes pain, infection, school absences, and undermines overall health status. So the picture on the right there was taken during one afternoon in theatre. And 16 of those teeth are from a 2-year-old child. So just a little bit on our catchment. So Chelsea and Westminster Foundation Trust cares for 80,000 children per year. 3 in 10 of the children in our catchment have visibly obvious signs of tooth decay. 1,555 children underwent tooth extraction, with 85% having multiple extractions. And this costs the NHS approximately £1,566 per child. So to respond to this local health need, an oral health prevention programme was jointly developed by the Public Health Department for the Royal Borough of Kensington and Chelsea, the City of Westminster, Public Health England, and Chelsea and Westminster Foundation Trust. So the aim of the programme was to equitably improve the oral health of paediatric patients admitted onto the inpatient wards through 3 intervention components. So the first being promotional activities, so that included posters and videos around the hospital. Supervised toothbrushing, which was a bedside intervention delivered face-to-face with patients and their families, and staff training.
The interventions were developed and overseen by an oral health program team involving representatives from Royal Board of Kensington and Chelsea, the Public Health England, Chelsea Westminster Hospitals, and the program governance was delivered through quarterly meetings when Chelsea Westminster Hospital team members presented data that were collected throughout the program, which were used as basis to discuss issues and progresses. The evaluation was supported by Arno West London Innovation and Evaluation team, while delivery and monitoring was supported by the Chelsea Westminster Hospital team. As you can see here, there are many actors involved in this program with different roles, and this is it was a real strength of this project. Program designs was conducted in accordance with the model for improvement, involving the development of the program theory for an intervention, followed by a series of PDCA cycles to test change ideas. As you can see here, the program theory has been represented using an action effect diagram, which allows to have a clearer picture of the program components by outlining the interventions, the major contributing factors, and linking them back to the main aim of the program. As you can see here are summarized some indicators and other data that were monitored throughout the program. For each of the three main components of the program, we have identified a quantitative key performance indicator alongside other qualitative and quantitative indicators to better explore the different aspects of the program. Data were collected between November 2018 and August 2021 for the supervised toothbrushing and health promotion activity data. Data were collected through a bedside survey, which was delivered by a oral health promotion coordinator to all patients and the family after the delivery of the supervised toothbrushing. Training data were collected through an online booking platform and an online staff feedback survey, and where appropriate, data were analyzing using statistical process control charts to explore data over time and also the potential impact of change interventions, while other data were analyzed using summary statistics and quantitative analysis. Change ideas were tested and refined using a series of formal and informal PDCA cycles. I'm sure most of you are familiar with PDCA cycles, which involve the planning of small-scale changes, carrying out the plan, then monitoring and analyzing learning, and based on these, identify new ideas for improvement. Now I will hand over to Laraib, which will present the findings of the first 2 years of the intervention.
So we asked families taking part in supervised toothbrushing if they had seen any oral health promotional material around the hospital, and 41% recall seeing some form of promotional material during their admission. Another interesting result was that those identifying as Asian or Asian British were least likely to report seeing oral health promotional material compared to those who were from a white or white British ethnicity. So these are the results for the supervised toothbrushing. We saw 737 children, and that averaged out about 35 children per month. The oral health programme reach is estimated to increase by 943 when taking into account learning reaching siblings. 54% of children receiving supervised toothbrushing lived in the most deprived areas. 57% identified belonging to a minority ethnic group, compared to 39% seen in our trust catchment. And lastly, those identifying as Black or mixed ethnicity were more likely to receive oral hygiene products compared to those of a white ethnicity. So just onto staff training, we wanted to create sustainability through educating the workforce on oral health in order to make every contact count. We trained 73 members of staff, and the cohort included a variety of different healthcare professionals. 84% of staff who completed the evaluation reported learning something new, and most of them also reported that they would do things differently, either with themselves, their families, or their patients. So lastly from me, just challenges and limitations. Supervised toothbrushing was heavily impacted by COVID, as was everything else. We had no delivery for 3 months. The other limitation was on downstream evaluation, so we could not assess impact. And lastly, the program was heavily reliant on an oral health coordinator to do program delivery. So if that member of staff was off sick or annual leave, it was very disruptive to the program, and you can see that on the run chart over there.
Thanks, Laraib. So we demonstrated that an oral health promotion programs can be an equitable approach to reduce pressure on the NHS through prevention. And we also believe that key learning from these projects can be applied to other hospitals in the NHS. Also, as Laraib was saying before, so as we were going through the COVID-19 crisis, it became more apparent the need to embed in the design of the interventions mechanisms to improve the flexibility of the program delivery. Also, through this experience, we learned the importance of evaluation, which is always a disregarded part of program interventions, of a program planning. And this, in our case, was delivered through the ARC support. So I want to highlight how the ARC play key role also in this, in trying to fill in these gaps in the system. Evaluation, we learned how evaluation is important for program improvement, but also for its sustainability and spread in other sites. Indeed, the evaluation of this 2 years program allowed us to gather further fundings to extend the program for another year at Westminster Hospital. And also we are planning to roll out this program also in other hospitals in London. This is all from us. Thank you.